Okay, so I don't know if Shintaro-san will uh, make the. Uh,
We are ready to go.
we are ready. Okay, so
Okay.
can you tell us if we can start now?
Yeah, please.
Okay, so okay, good evening and good morning and good night in Latin America. We are starting this first webinar from uh, AMEG and SIED, and also with the invaluable support from TEMDEC in Japan, from Kyushu University. And it is a very great honor for me to introduce you with the president of TEMDEC, Dr. Tomohiko Moriyama.
Hello, nice to meet you, everyone. This is Dr. Tomohiko Moriyama from Kyushu University Hospital. As a business trip, I'm now in Argentina. It's my honor to co-chair this session with Dr. Miguel Tanimoto. So thank you for joining us today.
Thank you, Professor Moriyama. And now I will introduce you to our first lecturer, is Professor Robert Becerra. He is currently an associate professor at Queen's University, and his clinical and research interests include POEM, ESD, magnifying endoscopy, diagnosis and resection of early gastrointestinal neoplasia. He completed a long training in the third space endoscopy fellowship under Dr. Haruhiro Inoue at the Showa University Digestive Disease Center in Koto Toyosu Hospital in Tokyo, Japan. His training in Japan included peroral endoscopic myotomy, peroral endoscopic tumor resection, endoscopic submucosal dissection, anti-reflux mucosectomy, and magnifying endoscopy. He's the leading endoscopy expert at Queen's University, and his clinical and research interests include POEM, ESD, magnifying endoscopy, diagnosis and resection of early gastrointestinal neoplasia. It is for me a great honor to introduce you to Professor Becerra, and he will present us a poem in difficult achalasia. Please, Professor Becerra.
Thank you very much, Dr. Tanimoto, and thank you, Dr. Moriyama, for the invitation. So I'm very excited and really honored to talk to everyone today about POEM in complex achalasia. So hopefully you can see my screen here.
Yes.
Okay. So, sorry, one moment. Okay. So these are my conflicts of interest. And in terms of the objectives, I just want to introduce POEM and the POEM difficulty score. And being familiar with some of the challenges in type 3 achalasia, patients who have had multiple previous treatments, and sigmoid achalasia. So in terms of the evolution of the myotomy, so it's really been the same treatment for over 100 years. It started with the Heller in 1914. It was initially an anterior and posterior myotomy, and eventually it evolved over the next 100 years to where it is now, where we have POEM as generally the standard treatment. Over 15,000 have been performed worldwide thus far. So why POEM? So it's an entirely endoscopic approach. Generally, patients have a shorter hospital stay, shorter procedure time, and a much quicker time to return to regular activities. They also generally have less post-procedure pain as compared to standard Heller myotomy. The big advantage is that the length and the position of the myotomy can be tailored to the patient, and it's effective in patients, even those who have advanced sigmoid achalasia, type 3 achalasia, and those that have had prior Heller. So we'll go over some cases. This is a case of an 82-year-old lady that was diagnosed with type 3 achalasia about 5 years prior, whose symptoms have now progressed despite 2 prior treatments, including pneumatic dilation and Botox. And you can see here her past medical histories, nothing particularly remarkable, pretty typical octogenarian. In terms of her symptoms, her Eckert score was 6. She didn't lose any weight, but she had dysphagia with every meal, occasional chest pain, and regurgitated food every day. This was her manometry. So you can see here, in terms of the hot colors are high pressure, and here you can see the spastic segment with a very high pressure, an IRP of 34 as well. And this is the distal spastic segment, consistent with type 3 achalasia. This is her barium esophagram, which looks almost similar to diffuse esophageal spasm. You have this corkscrew pattern here in the esophagus. And at 1 minute, the column of barium was about 15 centimeters. And at 2 minutes, there was no barium column. You can see the severe dysmotility that they comment on here in the X-ray report. This is her endoscopy. So we're basically just going down, and you can see there's a lot of very vigorous contractions. And every few centimeters, you think you're at the LES, but you're actually still in the mid-esophagus due to the very vigorous nature of these spastic contractions. And we're just advancing down here, and you can see it's also somewhat difficult to keep a straight luminal view due to the vigorous contractions that are constantly holding the scope and moving the scope. And there's the gastric side. So the next case is a 41-year-old lady. She has a 13-year history of achalasia and has had multiple previous pneumatic dilations with some improvement. She's otherwise healthy and recently had her symptoms progress in the past 1 to 2 years. So you can see here, in terms of the number of pneumatic dilations she's had, about 5 previously. In terms of her Eckert, it's 8. So she has dysphagia with every meal, chest pain every day, and regurgitation with every meal. And here's her esophagus. So at that time, we weren't doing timed bariums, but you could see a very dilated esophagus with retained material and this very acutely angulated distal esophagus, consistent with sigmoid achalasia. So this is her endoscopy. So we're in the stomach, we're in retroflexion. So you could see just with advancing the scope, you can see the squamous mucosa in the esophagus prolapsing out, which is indicative of a very tight GE junction. And then we'll de-retroflex, and you'll see it from the luminal view of the esophagus. So here is the forward view. So just withdrawing the scope. So very dilated esophagus, a lot of mucosal edema, and very acutely angulated. So this is all consistent with advanced sigmoid achalasia. The last case is a 53-year-old man with symptomatic achalasia since the age of 10, and he was referred for refractory achalasia and for potential POEM. So in terms of her past medical history, the most notable is his previous treatments for achalasia. So in 1987, had a transthoracic myotomy. Then he had a RAP a year later due to refractory reflux. A few years later, then he had a transabdominal extension and myotomy, and then a Nissen fundoplication. And then from 1980 to 2012, during that time, he had about 15 dilations. He's not sure of the nature of them. And then most recently, when he moved to our province, he's had a pneumatic dilation and Botox dilation. His Eckert was 7, so he had some weight loss, dysphagia with every meal, chest pain every day, and occasional regurgitation. Here was his barium. So you can see they mentioned moderate esophageal dysmotility. They didn't measure a barium column at the time, but you can see a fair amount of retained barium and a high barium column. So this was a manometry. So showing a kind of mid to distal esophageal spastic segment consistent with type 3 achalasia. And then this is endoscopy. So if you remember, he had a Nissen fundoplication previously. So here in retroflexion, the distal end of the esophagus actually looks fairly patent, which was consistent with the manometry where you had that mid-spastic segment. And then in the forward view, when we come back a little bit, you can see in a second a lumino-occluding contraction beginning in the mid to distal esophagus, which you can see right here, which is consistent with what we saw on manometry. So that distal area was patent, and then kind of this mid spastic segment. So now we're going to go over some of the challenging cases in POEM, so type 3, sigmoid, and multiple previous treatments, which will be kind of illustrated by those cases. So we had come up through a modified Delphi in terms of the different factors that were associated with a difficult POEM, and we came out with the score called the POEM difficulty score. You can kind of use the mnemonic foods to remember it. So fibrosis, submucosal oozing, orientation, the distension of the tunnel, and spastic contractions. I'll go over each of them and kind of show you what the scores look like. So what we did, we took 40 patients and we kind of POEM on them, and we compared the complex to non-complex patients in the short cohort, and we did their follow-up for the next 15 months. And you can see here in terms of the efficiency and the median POEM difficulty score. And essentially, we found that the order of increasing difficulty went from non-complex POEM, so type 1, type 2, non-sigmoid type, then type 3, then prior myotomy, greater than 4 procedures, and generally the most difficult were sigmoid achalasia. So this is showing you the score here. So no fibrosis on the left. So you can see nice translucent submucosa, very easy to see the tissue planes. Moderate fibrosis or F1 fibrosis looks kind of like a web-like appearance. So that would be 1. And severe fibrosis, where you can't really make out the planes between the muscle and the submucosa, which you can see here on the right. So this would be F2 fibrosis. In terms of submucosal oozing, absent to minimal, which would be a 0. So moderate submucosal oozing, which would look like this, where there's transient staining of the submucosa, and then diffuse oozing is a case like this, where there's a diffuse oozing, you can't pinpoint the one area, and the submucosal planes are obscured. In terms of the orientation, here on the left, we see easy. So we're proceeding straight with the tunnel. The scope is perpendicular to the muscle fibers, which you can see here. And it's a nice and straight tunnel, very easy to proceed. You don't get disoriented very much at all. Here on the right is a difficult orientation. So again, we're proceeding here. Initially, it looks like we're going straight. And again, we try to keep the muscle fibers perpendicular to the scope. And we're advancing here. But then things start to change a little bit, and we're a little bit unsure of how to proceed. So what actually happened here, that's the overlying mucosa. So this is the problem. We're actually in this area of the esophagus. And if we proceeded forward, we would just penetrate through the overlying mucosa and create a mucosal perforation. So we actually had to reorient and kind of flatten the fold, similar to when you're doing a sigmoidoscopy, to make sure we stay in the plane. So this is an example of very difficult orientation, which you can often see in sigmoid achalasia. And finally, or almost at the end, the distension of the tunnel. Here on the left, you can see a nice wide open tunnel. We barely have to insufflate any air. There's a lot of working space in terms of when we're doing the myotomy. And here on the right is an example of poor distension of the tunnel. So you can see I'm trying to do the myotomy, and the overlying mucosa is very close, and you're getting kind of very limited working space. So this would be poor distension of the tunnel, and this is good distension of the tunnel. And finally is the spastic contractions. So here's an example on the left, no or minimal spastic contractions in the luminal view. So you can see, again, very dilated esophagus, no spastic contractions really. The scope can easily advance. In the tunnel, it's very similar. Nice distended tunnel, no spastic contractions, very good maneuverability. Here on the right side, you'll see, again, very frequent spastic contractions. It's challenging to keep the scope kind of straight in the luminal view because these contractions are constantly squeezing the scope and moving it. And you'll see very similarly in the submucosal tunnel, it's similar. It's very challenging to move the scope because it almost feels like someone's holding it. because of all these vigorous contractions, which you can see some of them, and some of them you can't see because they're holding the proximal endoscope. And then multiple previous treatments. So in terms of the difficult cases, so things to look out for when patients have a lot of previous treatments for achalasia, they tend to have a lot of fibrosis, and it's usually at the GE junction, because that's mostly where treatments are focused in terms of Botox, pneumatic dilation, laparoscopic Heller. And oozing, you tend to see it as well due to kind of ongoing inflammation or mucosal inflammation. And in the area of multiple previous treatments, there's some neovascularization as well. In terms of type 3 achalasia, as mentioned, the orientation can be difficult because of the frequent contractions. The distension of the tunnel is also impaired in type 3 achalasia, again, because of the vigorous contractions. And they also can hold the scope, making maneuverability very difficult because it feels like almost like someone's putting their hand on your scope and holding it while you're trying to move around. Sigmoid achalasia is generally the most difficult. Fibrosis can be severe due to stasis. There's a lot of neovascularization from the edema and the chronic inflammation. And orientation can be challenging as well due to the thick and disordered muscle fibers. And as I showed you that case earlier, you can think you're at the GE junction, but it's actually just an acute angulation. So as I mentioned earlier, the order of increasing difficulty of the POEM difficulty score we found went from non-complex to type 3, prior surgical myotomy, greater than 4 treatments, and then sigmoid achalasia. So this is quite useful when you're training someone in POEM, as you generally wouldn't want to start with sigmoid achalasia. And this gives you kind of a framework for advancing the training and the cases in a trainee, or if you're early on in your POEM experience, of how to progress with your subsequent cases. Rather than going from non-complex to greater than 4 treatments. So it gives you kind of a progression of how to advance your training. So we'll get back to the cases. So the first lady, the 82-year-old lady with type 3 achalasia with a 5-year history and kind of recent decline of her symptoms. So this was her POEM. So we ended up doing a 19-centimeter myotomy. So here we're injecting. And then we do a very superficial incision just of the epithelium until we get to the submucosa. We do about a 2 to 3 centimeter incision. And then we'll get into the submucosa and we'll tunnel down to the gastric side. So here we just got into the submucosal space, and then we'll just dissect the submucosal fibers. Here is the completed tunnel. And then we'll do the myotomy. So you can see in her case, which is not atypical of type 3, that's a very thick muscle and a lot of spastic contractions, making it very difficult to complete the myotomy. So sometimes you have to cut from over and go down rather than from down up, which is the typical way, because you may damage the overlying mucosa. So you can see how maneuverability can be challenging in these cases. So her case at that time took 92 minutes. Her difficulty score was 3. So it's now probably about 70 months or so after her POEM, but she's asymptomatic, eating and drinking well, without any symptoms whatsoever. And her pre-POEM score was, Eckert score was 6. This is her barium, so pre and post. You can see things empty very well. There's no barium column at all. And then her pre and post manometry. So you can see that spastic segment is completely gone and the LES is nice and relaxed with an IRP of 13. The next case was the young lady with the multiple previous pneumatic dilations and the advanced sigmoid achalasia. So here you can see again, very edematous mucosa. So submucosal injection, again, a superficial incision, and then tunneling down, you can see there's maybe F1 fibrosis. So again, we very carefully proceeded with the tunneling and subsequent myotomy, which I'll show you here. So you can see again, a very thick muscle, but here you can see the tunnel is nice and distended. It's very easy to advance. Your working space is nice. It's not tight like the last case with the type 3 achalasia. So we complete the myotomy and then closure. And she's been quite well after her POEM, only intermittent dysphagia, but otherwise is doing very well. And here is her pre and post to show you an endoscopic change. So if you remember pre, with advancing the scope, there's squamous prolapse. And if you see here on the right, the GE junction is patent and patulous. There's no squamous prolapse. So nice, relaxed esophagus. And finally, the last case, the patient with the advanced type 3 achalasia and many, many treatments in the past. So this is his myotomy. So similar, inject, incise, tunnel down to the GE junction. And you'll see here in a second, in terms of the GE junction was very scarred and a lot of, you can see almost adhesions, and there's some sutures, which you'll see in a second. So very difficult to make out the anatomy at the GE junction. But if you stick to the same principle, just stay above the muscle and very slowly dissect, things generally will go well. The myotomy was completed fairly easily. And again, we see here endoscopically, everything was nice and relaxed. The GE junction was patent before, but now here, the spastic segment you can see is nice and relaxed. We don't have those high pressure contractions anymore. So he has been well post-POEM, occasional regurgitation and occasional dysphagia, but otherwise much better than prior. This is his pre and post barium. You can see here the high barium column, and here things very rapidly empty. And here is his manometry pre and post. Again, that high pressure segment is completely gone. So in conclusion, POEM is safe and effective for even complex achalasia. The aspects that contribute to a challenging POEM include fibrosis, oozing, orientation, the distension of the tunnel, and spastic contractions. And the order of increasing difficulty of POEM appears to be from non-complex type 1 and type 2, type 3 achalasia, prior myotomy, greater than 4 treatments, and finally sigmoid achalasia. Thank you very much.
Thank you very much, Professor Becara, for your wonderful presentation. And I remember everybody at the webinar that we will have a time for questions and answers at the end of the webinar. So please put your questions in YouTube, in the YouTube platform. And also, we will try to answer to all of your questions. And our next presenter will be Professor Minoda from Kyushu University. He is an assistant professor from the Department of Medicine and Bioregulatory Science. And he's a member of the Department of Hepatology and Pancreatology at Kyushu University Hospital. He has a PhD from the Kyushu University. He also has more than 90 publications of high impact and more than 300 citations. His research interests are gastrointestinal mucosal barrier function and dysmotility of the gastrointestinal tract. Also, the efficacy of endoscopic ultrasound with artificial intelligence for the diagnosis of gastrointestinal stromal tumors. So it is an honor for me to present you Professor Minoda from Kyushu University, and he will be our next presenter. Please, Professor Minoda.
So thank you, Dr. Miguel. So it's a great pleasure for me to talk here in this meeting. So I will share my slide. Please wait. So can you see my slide?
Yes.
Okay, so today I will talk about our advanced technique in gastric and duodenal defect repair. So first, I want to explain myself. So my name is Yosuke Minoda. My specialty is gastrointestinal tumors, especially for our ESD or sometimes do our interventional ES. And so I graduated the Nagasaki University here. But now I'm working in Kyushu University Hospital here. So my hometown is Fukuoka City. So someone knows about my hometown. This is because my hometown is very famous in the ramen or sometimes very delicious food. And also they're very famous singer or Julian Luis Gallela sung my hometown. So first, I want to explain about the history of endoscopic resection. So this is a history. So as the first generation, EMR was started, and then next, ESD come appear. And recently, EFTL is sometimes have a big topic. And gradually, the post-treatment defects are becoming larger and sometimes very deeper. For example, when we did do our EFTL, of course, the defect is a very deeper and complete defect we can see. Muscle layer is also resected. In Japan, this EFTR procedure is not covered by national insurance. And so today I will mainly talk about the mucosal defect after EMR in the ESD, but sometimes I will talk about our wall defect. So this is today's agenda. So when the post-ESD and EMR ulcer should be closed. So please remember 3 situations. So as you know, there is no need to close post-ESD ulcer generally, especially in the gastric ESD. So many reviews showed there is no statistical difference between clipping after ESD, the delayed perforation rate or post-ESD coagulation syndrome will not decrease. However, in high-risk group, post-gastric ESD should be closed, in my personal opinion. But so recently, very big study was analyzed in Japan. In this study, about 8,000 gastric ESD case was analyzed, and so the patient was classified into bleeding list using a scoring system. For example, when the patient have our chronic kidney disease with hemodialysis or they are taking on medical care with warfarin or DOAC, they are classified into a very high-risk person. In that group, the bleeding risk is very high, about 30%. And so this is a very good point. Usually, we don't have to close the post-ESD ulcer, but in the very high-risk group, it is a very good option to close their ulcer. And the second situation, post-duodenal ESD or EML ulcer should be closed, even in non-perforation cases. As you know, during the procedure of duodenal ESD or EMR is very dangerous. This is because duodenum wall is very thin and sometimes difficulty obtaining a good lifting sometimes. And after procedures, pancreatic juice and bile juice will be sprayed to our ulcer, and which lead our delayed perforation, even in EMR. And some report showed the efficacy of closing of duodenal ulcer post-ESD or EMR. Interestingly, the delayed perforation will occur usually within 3 days after procedures. And so you should keep ulcer closed for at least 3 days. And the final situation is perforation should be closed. And when we see our clinical practice update published by AGA guidelines, endoscopic sutures such as our clip or OTSC is used for perforation of less than 2 centimeters. When we encounter the perforation, which is larger than 2 centimeters, we have to suture using a combination of end suture or snare, OTSC, or crepe. If so, we have to know how to close the defect. Today, so of course, I know there is so many methods to close but now I will show the main 4 types of closure method. So first one is the most popular one. Sorry. First we have to know why we have to combine some method to close the big ulcers. This is because clip-only suturing have a very low success rate. Only 59% of post-ESD ulcers could be successfully closed using only clips. And so an assistive device is necessary for closing a post-ESD ulcer in the stomach. So what is the assistive device? So this is the most popular and famous one, loop with clip method, closing the snare after fixing to the edge of a mucosal defect using clips. So recently in Japan, some dedicated device is available. When we use this type of end loop or flex loop, we can easily close the mucosal defect with the combination of loop and clips. After putting many clips to the edge of the ulcers, finally, we can close the ulcer like this. When pull back the line, the ulcer is closed, will be closed. So this method have an advantage. So this is a very cheap method, not so expensive. And so I think this is a very popular way to close the mucosal defect. And this method can be used in another part, for example, colon or duodenum, or of course in a stomach. So in our data, you can keep ulcer closed for at least 3 or 5 days when you use this clip with thread method. So, sorry. Another way is a traction band with clip. So very similar way to our, many similar way is published in the English literatures. For example, we call it T-bag. For example, when we use this T-bag method for collector ESD, after finishing the ESD, we can close the ulcer using this method. First, we will put the clip with loop and then we will put the clip to the opposite side of the ulcer. And after shortening and smalling the ulcer, we can close the post-ESD ulcers only with clip. So, but now I want to show your new devices to close the defect. So in North America and sometimes South America or Middle East America, this type of overstitch would be famous, all-in-one system to sutures. But this system is not available in Japan. On the other hand, in Japan, we can use a hand suturing device. So when we use this device, we can use our needle with line, so which is used for our surgical treatment. When we use this hand suturing device, we can close the ulcer like this. I will show you some procedures in my hospital. After ESD, gastric ESD, we can close this ulcer using this endoscopic hand suturing device. We can suture the ulcer continuously like this. And gradually the ulcer size is shortened. And finally, we can close the ulcer completely. So this method have our advantage of our suturing. So when we use this device, we can close the ulcer for a complicated shape. Of course, it requires very high endoscopic skill, but we can close. So furthermore, when we use this device, we can close a wall defect. So this is our report from our Professor Goto. He is the developer of this hand suturing device. He did our EFTR for GIST case. And after finishing the resection, now we can see a big wall defect. He closed the muscle defect using this hand suturing device first. And after finishing the closure of muscle wall defect, and then he closed the mucosal defect. And so when we use our this method, we can close the wall defect in the double layer suturing, like our surgical or procedures. And furthermore, this endoscopic hand suturing device can close also the fistula tightly, even when OTSC was not success. So we encountered the fistula case for our acute pancreatitis. We tried to close the fistula here after drainage. So we tried to use the OTSC device, but it was not success. And so we did our burning for our mucosa to promote the healing. And then we closed the ulcer with a hand suturing device like this. After 1 month, the fistula was tightly closed. And so we can close this fistula successfully. So another way is also published. So this is called lorem reopenable clip over the line method. So in this this Oh, Dr. Miguel?
Yes, probably we have some connection problems. Yes, But now maybe we can continue with the transmission by YouTube. Now I think that we have a good connection.
Yeah, Minoru-sensei, would you restart from the Rome, introducing Rome procedure?
Okay. From this slide, Dr.
Yes.
Moriyama.
Please share your slides.
Please share.
Okay, sorry. Can you see my slide?
Not yet.
Thank
Yeah.
you.
Yes, from this one.
Okay. So now the new method. In this method is our combination with our conventional clip and with line. So this clip is used with lines, sorry. So so endoscopists use a clip with line like this gradually. The ulcer will be closed. This line is used for anchor, and after finishing the closure, this clip with lining in one side. But for this method, you have to use a clip which have a hole in the top. So in Japan, the only one clip called the Sure Clip. This is made by our Chinese company. Sure Clip is only device to do this device. After the line is fixed to our clip, and the one side is clipping, and the next clip is put in the another side. After putting the clip, we can close the ulcer. We can close the ulcer after pulling the line, and finally, we can close the ulcer like this. So regarding to a wall defect, we have a three-way to close: endoscopic hand suturing and OTSC and roll. But in my personal opinion, each way have their own advantage and disadvantage. For example, endoscopic hand suturing method has a very big closure power and closable size is large. But on the other hand, this method requires very large working space and procedure time is very long. On the other hand, OTSC devices require very short procedure time and required very not big working space. On the other hand, this OTSC can close a very small size ulcer only with one OTSC. To summarize, the management of wall defect, it's my personal opinion, but so when you see a perforation or small wall defect, you can close only with clip. But when you see a middle or large wall defect, you have to use an assistive device or a new device, roll or hand suturing over several OTSCs. On the other hand, when you want to close a mucosal defect, for small mucosal defect, you can close it only with clip. But when you want to close a middle or large size mucosal defect, you have to use our assistive device. Also, same to our wall defect. So this is the take-home messages. Post-ES endoscopic treatment ulcer of duodenum should be closed even in non-perforation cases. So in a high-risk group of gastric ESD cases, to closer post-ESD ulcer would be a good option. So, and finally, clip-only sutures have a low success rate. Large defects require assistive device or new device. Thank you for your kind attention. I will finish my presentation. Thank you very much.
Thank you very much, Professor Minoda, for your wonderful presentation. And I will have the last presentation of Professor Uedo. The last presentation of this webinar will be from Professor Uedo. He is the Vice Director of the Department of Gastrointestinal Oncology at the Osaka International Cancer Institute. And he is also a visiting professor at the University Hospital in Cleveland, Case Western Reserve University. And he was also a visiting professor at Malmö University Hospital, Lund University in Sweden, and also a visiting professor of the Department of Gastroenterology at 301 PLA General Hospital in China, and finally a visiting professor of the Department of Endoscopy at the Fukuoka University Chikushi Hospital. He's a consular Japanese Gastroenterological Endoscopic Society, also a counselor of the Japanese Society of Gastroenterology, a counselor of the Japanese Gastric Cancer Association, and a counselor of the Japanese Esophageal Society. He's an international member of the American Society of Gastrointestinal Endoscopy and associate editor of Digestive Endoscopy, associate editor of Annals of Gastroenterology, and associate editor of Endoscopy International. So we will see his video recorded presentation. Please, you can start.
Ladies and gentlemen, thank you for invitation to this webinar. And today, I'm talking about the underwater endoscopic mucosal resection for gastric lesions. I'm explaining about the background and rationale for underwater EMR, and I want to share the cases and tips and tricks. On the background, ESD is established as a standard treatment method for early gastric cancer. However, it is somewhat time-consuming and expensive because it uses many devices and skill-demanding, especially for small regions located in a difficult area. An injection EMR is a practical alternative, but especially in the stomach, it is often difficult to snare the region without lifting devices such as grasping forceps, aspiration cap, or a ligation band. And the efficacy of underwater EMR is reported for colorectal and duodenal lesions. So I want to explain the concept behind the underwater EMR procedure. This method was initially developed by famous endosonographer Ken Bimmer. So during EUS, he found that the only mucosa and some mucosa is protruded into the lumen. However, the muscularis propria is always stay circular behind the submucosa. So in this situation, if we capture the mucosa, the chance of perforation does not increase much. This method was initially reported for colorectal lesion, but after that, same procedure was reported for duodenal lesion as well. So for rationale, the lumen is expanded in the air, so the lesion becomes large and flattened, and the mucosa becomes dense. so the snaring can be difficult. However, under the water, the lumen is collapsed, so lesion becomes smaller and then protruded into the lumen and becomes polypoid. And the mucosa is soft, so easy to capture the mucosa, including the lesions. Previously, we have conducted the randomized control trial of underwater AMR for colorectal lesion size between 1 to 2 centimeter, and then we found that the underwater AMR significantly improved the R0 resection rate and unblocked resection rate for these lesions. I want to explain about the technical tip of underwater AMR. To submerge the lesion, if there is air under water, always it creates a pressure gradient. So the air always pushes the water away from the procedure site. So initially, it is very important to completely collapse the lumen and then infuse the water so that the water is stay at this site, and then we can submerge the lesion. So in the stomach, it is important to suction all the air, especially in the antrum, and then totally collapse the gastric lumen, and then infuse the water. Another technical tip for underwater EMR is marking. In ESD, we usually put marking a few millimeters away from the margin of the lesion. However, underwater MR, it is better to put marking just next to the margin because it can act as an anchor and then facilitate capturing the lesion like this. For snaring of the lesion, you can put the snare from top to bottom like a conventional EMR. But under the water, sometimes mucosal fold becomes very close to the lesion. So it is useful to put the tip of the snare to just distal to the lesion and then separate the fold and then open the snare and capture the lesion like this. Another useful technique during underwater EMR is a torque and crimp technique. In this technique, we anchor the tip of the snare just distal to the lesion and then slightly shaking or sometimes suction the water to crimp the surrounding mucosa in order to capture more tissue in the snare. So I want to show the example. So this is the polypoid lesion located in a greater curvature. The biopsy showed adenocarcinoma for this lesion. With NBI, we can observe irregular vessel, and it is very important to check there is no flat extension on the base of the lesion. So we found that the irregular vessel is confined to the polypoid area and decided to perform underwater EMR. So the lumen is totally collapsed. Especially important to suck the air in the antrum. And after marking, we fix the tip of the snare to the just distal to the lesion, and then we capture the mucosa, including the lesion. Another benefit of underwater MR is that we don't inject the solution, so the surrounding mucosa is soft and easy to put a clip. And the lesion was completely removed like this. So this is another lesion. The lesion located in the posterior wall of gastric corpus. The lesion looks very flattened, and we confirm the edge of the lesion with magnifying NBI. We put marking just next to the lesion. So in the air, it looks very superficial and flat, but under the water, it becomes a bit smaller and then polypoid. And the surrounding mucosa is also very soft. So we fix the tip of the snare just distal to the lesion, and then open the snare and suction the water a little bit. So the mucosa is come inside the snare, and the marking is anchoring the mucosa. And we can capture the lesion, including surrounding mucosa. So after that, we encounter the bleeding from the submucosa. And this is the new image enhancement mode, red dichromatic imaging, RDI. In this imaging, we can evaluate the bleeding point better than the conventional white light. And in this situation, I use the cap to stop the bleeding. And then identify the bleeding point and apply the coagulation forceps to coagulate the vessel. And the lesion was completely removed in this technique. So the lesion was removed, including the marking, like this. So previously, we have done underwater AMR for gastric lesion in 32 patients. Median tumor size was 1 centimeter. So basically, we apply this technique for small lesion. More than a half of the lesion located in the greater curvature. Because the lesion in the greater curvature, sometimes ESD is very difficult and challenging. About half of the lesion was early gastric cancer, and 8 lesion was adenoma. Probably we are selecting good case for underwater AMR. It means small lesion located in a greater curvature. The median procedure time is only 4 minutes, compared to ESD, significantly short time. And we experienced 1 aspiration pneumonia, but severe adverse events was not experienced. For 15 early gastric cancer lesion, endoscopically complete resection rate was 100%, and histological R0 resection rate was also 100%. But to make sure, we select good indication lesion for underwater AMR. Recently, we published the usefulness of underwater AMR for gastric lesion in patients with familial adenomatous polyposis. So in this case series, we found that the underwater AMR showed the unblocked resection rate of 88%, but R0 resection rate was not so good as 56%, but the actual local recurrence rate was quite low, 4%. And the adverse events rate is quite low as well. Another interesting thing was we experienced 4 residual or local recurrence in this case series, but most of them could be managed by underwater EMR. So this is example. lesion was 5 centimeter superficial lesion located in a greater curvature. Initially, we tried to perform ESD, but there's many polyps around the lesion, and the greater curvature location was very difficult to perform ESD. We tried to dissect the submucosa, and then eventually we experienced the perforation. Because the conventional clip was very difficult to apply, so we put OTSC over the scope clip to close the perforation hole, and then terminated the procedure. And 3 months later, there was still some lesion was remaining. You can see micropapillary structure of neoplasia among the smooth surface polyposis. So in this time, we try to remove this lesion with underwater EMR technique. Fix the tip of snare distal to the lesion. Under the water, flat lesion become polypoid, and we could capture the lesion with a snare like this. After initial resection, we capture the lesion next to the previous wound subsequently. When we inject the solution, sometimes such kind of small remnant is very difficult to capture. But under the water, mucosa remains soft, so easily capture the lesion subsequently to the previous resection. And if we continue this type of procedure, the lesion was completely removed like this. And follow-up examination did not identify the remnant lesion near the OTSC clip. Usefulness of underwater EMR for local residue was also reported for colorectal lesion as well. So if we inject the solution, only surrounding mucosa was lifted, and we cannot capture the remnant lesion after injection EMR. And eventually it was ablated like this. However, the underwater EMR, even though the lesion located in a scar, we can capture the lesion and the mucosa like. So this is an example of salvage underwater EMR for recurrent lesion after gastric ESD. Post-ESD scar is widely fibrotic, so skillful doctor is okay, but very difficult to perform ESD again. And also injection does not lift the lesion very well. However, under the water, we can efficiently capture only lesion, even though it is located on the scar. And the lesion is removed with complete resection. So in summary, underwater EMR for gastric lesion is safe, easy, and efficacious alternative treatment option to conventional EMR or ESD for small gastric lesion, especially it located in a greater curvature. And also it is beneficial for recurrent lesion after endoscopy treatment. Thank you for kind attention. Muchas gracias.
Thank you very much for your wonderful presentation, Professor Wedo. And I have some questions from the audience to our lecturers today. And I have one question for Professor Becerra. And this question is, what is the role of poem F? And does this poem F still experimental? And do you think it is necessary at this point?
So, good question. So, poem F is kind of poem with funduplication, an endoscopic funduplication. And it's, I think, in my opinion, at this time, I think it's still evolving. It definitely does show that there's a decreased incidence or decreased requirement for PPI use after. But it's still, as it's an evolving procedure, and we don't know the durability of it at this point. In my experience, though, we don't have any patients that required surgical funduplication after POEM. Everyone, should they develop severe GERD, respond very well to PPI. But I think there may be a role for it down the line after the procedure is kind of evolved and is a bit more mature, and we have more data on its durability for achalasia.
Oh, thank you. Thank you, Bob. And I have a question to Professor Minoda. And does all middle and large ESD defects requires some method for close the post-procedure defect?
Again?
Now, do you think that all middle and large ESD defects requires some closure method?
So you mean what kind of assistive device is suitable for or closure for large or middle-sized defect?
No, if it is necessary.
Okay, thank you so much. So in a gastric ESD, in a gastric cases, I think we have to necessary to use our assistive device. Okay, but on the other hand, when you want to close a colorectal ESD or another part, the situation is quietly different. Especially in a colorectal ESD, sometimes you can close only with clip, but in a stomach, you have to use our assistive device.
Oh, thank you. And I have one question to Professor Uero, and it is there is a type of snare better for underwater EMR?
Actually, I have no exact data, comparative data, but in my practice, I prefer thin snare. It's easy to capture the soft mucosa efficiently. So I prefer thin snare. Sometimes monopolar snare is good. When I was in Sweden, I always use monofilament snare for the underwater EM procedure. Yes.
Thank you. And I have one more question to Professor Becerra. Do you think a previous pneumatic dilation for achalasia makes more difficult to perform POEM?
So I think a single balloon pneumatic dilation doesn't generally make a difference. So there's some old literature from the surgical literature and some from the endoscopic literature, and it varies in terms of the number of previous treatments. Some say 2, some say 3 or 4 or more, but generally, in my experience, I found that 1 or 2, sometimes even 3 doesn't make much of a difference. It's when you start getting up to 4 or more treatments. And same with Botox. So sometimes referring physicians are scared to give a patient Botox. They say it will ruin their subsequent procedures. But I haven't found that it makes a big difference if it's 1 or 2 treatments. When it starts getting up to 4 or more is when you start seeing a bit more fibrosis. But none of the treatments make it impossible to do the POEM. It just makes it a little bit more difficult, but it will never, make the procedure not doable if it's done by an experienced physician.
And I have one question for Professor Wedo. Do you think it's a risk of respiratory aspiration when performing underwater EMR? Do you carry out airway protection in all your procedures?
Yes, actually, in my practice, we don't use intubation or even even over tube, we don't use it. And but we make the patient head up position. So we put some. Our hospital bed can be moved, so we keep the patient head up position. And also, we try to avoid too much insufflation. As I mentioned, sometimes too much insufflation also cause some reflex of the stomach water. So that is, I think, tip of the procedure.
And also, do you change positions many times during EMR, underwater EMR, in order to contain water inside the stomach?
Yeah, that is also, I always ask, but as I explained, the principle. So if the lumen is totally collapsed, usually water is only stay there. So usually we almost always, we keep the patient in the same position and then complete the procedure.
And one last question to Professor Becara. Do you manage mucosal and muscle perforation during OM?
So I guess the muscle perforation, so basically penetrating the muscle doesn't really matter if you keep the overlying mucosa intact. So you do the myotomy. So I guess they're asking if you sever the longitudinal muscle in the peritoneum or mediastinum. So generally you don't need to do anything if that occurs. The important thing is you keep the overlying mucosa intact. So if you do sever the overlying mucosa, generally that's easily managed by just simple clips. So if there's a small focal defect in the mucosa, just using clips, closing them, very slowly from the luminal side is generally adequate, and it doesn't change the patient's course in terms of the recovery and the final result for the patient.
Yeah. Oh, thank you very much for all the presenters for your wonderful participations. And I want to ask you if you have some final remarks for your participations. Professor Moriyama.
Oh, so sorry. Right. Okay. Thank you again
Final
for
message.
the presenters. Thank you. Thank you presenters for your wonderful and excellent presentation to us. We really appreciate it because maybe it's really nice to share your knowledge and the tips and tricks for the new procedure, and introducing new procedure is quite useful for our daily practice and can be implemented from now on. So we would like to learn more from you guys, and so I would like to say thank you for your experience and sharing with us. Thank you so much.
Thank you. Thank you very much to you all.
Thank you very much.
We will inform you about the
you.
next symposiums. Thank you very much. Have a good night, everybody, and good morning.
Take care, everyone. Thank you.
Have a nice day.